The COVID-19 Immunity Task Force and CanCOVID have partnered on a monthly event series, Research Results and Implications, to offer researchers, policymakers, and Canadians with the latest COVID-19 related results. To learn more about how both organizations have been helping to inform public health policy during the COVID-19 pandemic, please visit our websites at covid19immunitytaskforce.ca and cancovid.ca.
Okay, well, good afternoon or good morning. I'm Tim Evans, one of today's speakers. I've been asked to share some brief instructions for our French attendees so they can access the live translations. Bonjour, je m'appelle Tim Evans, je suis un des l'orateur aujourd'hui. On m'a demandé de partager quelques brèves instructions pour nos participants français afin qu'ils puissent accéder aux traductions en direct. Alors, à l'attention de nos participants francophones, nous vous invitons à vous rendre au bas de votre écran Zoom où se trouve une icône ressemblant à un globe. Pour indiquer votre langue de préférence, cliquez sur ce globe et sélectionnez French. Dès que notre conférencier commence à parler, vous allez entendre notre traducteur. En tout temps, si vous souhaitez revenir à la version anglaise, vous n'avez qu'à cliquer sur le globe et à sélectionner Off. De plus, vous verrez qu'une version française de la présentation a été partagée dans le Q&A. Si vous désirez suivre la présentation française uniquement, alors tous nos présenteurs aujourd'hui présenteront en anglais. We'll take a moment now to allow our French attendees to turn on their live translation service before I introduce the moderator. We've given them that time, so it's my pleasure to introduce our moderator today, Dr. Nathan Stahl. Dr. Stahl is a CanCOVID Network Science Advisor, staff geriatrician at Sinai Health, and research fellow in the Departments of Medicine and the Institute of Health Policy, Management and Evaluation at University of Toronto, and at Women's College Research Institute at Women's College Hospital. Despite his very busy schedule, Dr. Stahl has graciously agreed to be our moderator today, and we're enormously grateful, Nathan. Thank you very much. I'll turn things over to you now.
Thank you, Tim, for your kind introduction. And of course, for your help in setting up the French attendees with the live translation. Welcome everyone to CITF and CanCOVID's second installment in their new seminar series, Research Results and Implication. Our topic today is, of course, protecting Canada's long-term care residents from COVID-19 and the evidence behind the policies. Before we dive into the presentations, of which there are several, I'd like to add that you don't have to wait until the end of today's event to ask your questions. Simply enter them into the Q&A section at the bottom of your screen, and I will ask our speakers as many of the questions as possible during our Q&A session at the end of the presentation. I would now like to introduce our first speaker of the day, Dr. Timothy Evans, whom you just met as he lent us his French skills. Tim is the Executive Director of the COVID-19 Immunity Task Force, also known as CITF. He will be sharing with us today a brief overview of CITF's areas of research and various studies. Tim, back to you.
Great. Thank you very much, Nathan. And we've got a very long list of speakers, so I'll try and be very brief here in introducing the task force and the focus of today's seminar. Next slide, please. So just a little bit on the community COVID-19 Immunity Task Force. We were established in April of 2020. That seems a very long time ago, to support research on issues that are really germane to COVID immunity, aligning studies across the country, and with a view to trying to provide useful information to our federal, provincial, territorial decision makers. Next. These are some of the areas that have been priority focus for the task force: seroprevalence studies, immune science, immune testing, and vaccine surveillance. Of course, all of these often come together in the studies that we support, but we've had working groups really trying to push the frontiers on these boundaries. Next. We've got, at this moment, about 108 studies that are rolled out across the country and really addressing some of our priority areas that I described earlier. Next. Today's focus is going to be on long-term care. There are a number of reasons for this. First is that the epidemic, as it rolled out, as the first wave crashed, it crashed most impressively in long-term care homes that unfortunately have not been in the mainstream of health research. And I think this was recognized quickly and led us to create a focus on long-term care settings in what we call the hotspots funding competition. And out of that, we mobilized a tremendous set of researchers, 7 of whom are presenting today, and I think really making it clear that not only that research, first-class research is possible, it's absolutely imperative in the setting of long-term care. Next. So this is how it looks. Each of these investigators are geolocated in these bubbles across the country, and they will be presenting today. So I won't go through them all here, but just to say that it's a pretty impressive swath in terms of representation, and as you'll see, the set of questions that are being asked and which have generated, I think, really interesting and pertinent results in a timely way. Next. So we're keen to note that this long-term care group have already mobilized and pooled results in September, and those results were presented to NACI, the National Advisory Committee on Immunization, and helped inform their guidance to government, recommending a third dose third vaccine dose to residents in long-term care. So I think the translation of evidence to policy has been very front of mind and actioned effectively, thanks to a tremendous amount of work from everybody who will be presenting today. Next. So back to you, Nathan.
Thank you, Timothy, for providing that overview of CITF and for the work, really important work your team is doing there. Our next speaker is Dr. Dawn Bowdish, an associate professor in the Department of Pathology and Molecular Medicine and Canada Research Chair in Aging and Immunity at McMaster University. She'll be presenting on COVID-19 vaccinations and infections in long-term care. Dawn, welcome.
Thank you so much for having me and allowing me to present on behalf of my team. Could I have the next slide, please? The vaccination effort in long-term care has been nothing short of miraculous. The fact of the matter is people who live in long-term care are often older, they have very complex health conditions, and they're frail. And this frailty remodels their immune response to the point where in many cases they don't respond well to vaccination. Had this been an influenza pandemic, we might have been better served by vaccinating the staff, the visitors, and relying on all the PPE and the isolation instead of vaccinating seniors, our long-term care residents. And that's because, in general, vaccinations do not work particularly well in this population. However, the mRNA vaccines that we've used have been absolutely mind-bogglingly effective in protecting long-term care residents in the short term. If you look at on the graph here, when the start of the vaccination program began, you can see that the rate of those infections just decreased really rapidly. Unfortunately, the news that I'm about to share with you, and you will see again and again over the course of today's talks, is that these immune responses don't seem to last very long. And this is one of the reasons we in this group have recommended a third dose. Can I have the next slide, please? There are many different ways of measuring the immune response, and I always say you never get a straight answer out of an immunologist about what is actually protective. There's the types of antibodies, the amount of antibodies, but there's also one really important measure that I'm showing you here, which is how well they stick to the virus. In many cases, older adults and frail adults and people with complex medical conditions can respond to a vaccine, but they don't necessarily make the high quality antibodies that stick to the virus and stop it from getting into the cells, like I've shown you here. The data I'm showing you on the right-hand side is the results of several hundred residents of long-term care. And I've color-coded the people into people who are in the green zone, who have nice, sticky, high-quality antibodies that are about what we'd see in a young individual. Then we have folks who are in the red zone. The red zone's problematic because either they don't have any detectable ability to stick to the virus, or it's so low that we wouldn't expect them to be protected. And what we found is that in the first 2 to 4 months, the blue line indicates that half the people are above, half the people are below. So in the first 2 to 4 months, over half the people we thought would be in this green zone of protection. But by 6 months, we found that the majority of people were actually in this red zone. We would not predict that their antibodies would protect them from infection. And just to give you a bit of a comparator, I'm showing you a sister study that we're doing looking at healthcare workers and people who've recovered from infection. Next slide, please. There were a few interesting findings here. We, as you know, use both the Moderna and the Pfizer vaccine in long-term care. And these vaccines are, in young, healthy adults, probably fairly comparable. But there are some key differences which seem to affect the antibody quality and quantity in long-term care residents. So if we compare Moderna or Spikevax, as we're now calling it, or the Pfizer or Comirnaty, or however you pronounce it, you can see that when we look at the number of people 6 months after their infection who are in that green zone versus the red zone, the Moderna vaccine performed better. And more of those people are in that green zone, very comparable to the healthcare workers or the people who'd recovered from infection. So what is the difference between these two vaccines? Although they're effectively the same in that they both show a very similar part of the virus to the immune response, Moderna is a higher. There's more of the active ingredient in there, about 3 times more. And similarly to the high-dose influenza vaccine, which just shows the aging and frail immune system a little bit more of the antigen, so does Moderna. There's also a longer interval between the two vaccines, 4 weeks instead of 3 weeks. And we now know that spreading those 2 doses out seems to be particularly effective in protecting and creating high-quality antibody responses. We hope that we can use these data to sort of make decisions about who might get which vaccine to really optimize use. Could I have the next slide, please? And I just want to show you that these vaccines, despite the fact we and all the other talks you're going to see today speak to waning immunity, they have been incredibly effective, and we're not seeing a huge number of breakthrough cases. The figure on the left is showing them specifically in long-term care. There's actually, if you go to Public Health Ontario and Google, there's a new one that came out today that showed that that little peak of these breakthrough infections that were just starting 6 months out of the infections looked like it was the beginning of a really worrisome trend. So it's important that we got these 3rd doses in. Our current research is also understanding which cells of the immune system are not doing their job and not working very well in these, in hopes of designing new and better vaccines for the long-term care, understanding how people who had previous infections deal with the vaccine, and understanding which drugs, medications, and health conditions may be affecting the immune response so we can target these people for more interventions and protection. Next slide, please. So I'd just like to acknowledge all my co-investigators, and next slide. Importantly, my dear colleagues, Mylin Duong and Daryl Leong shared the healthcare worker data with me to share with you today, and Isaac Nazi, who shared us the data from the healthy people. I also need to thank our incredible partners for giving so much to this study to help protect their residents living in long-term care and retirement communities. Thank you for listening.
Thank you, Dr. Bowdish, for sharing your work with us today, and for using the updated names of the COVID vaccines, and also for giving us a look ahead at what you and your team are looking at. I'll now pivot and introduce our next speaker, who is Dr. Alison Mcgeer, a professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto, and a senior clinician scientist and infectious disease physician at Sinai Health System. Dr. Mcgeer will be presenting on her work on the Wellness Hub Immunogenicity Sub-Study. Alison, we're all set to hear more about your work.
Thanks very much, Nathan, and good morning and good afternoon, everyone. It's a pleasure to present on behalf of a large number of investigators of a sub-study of a larger wellness hub study. If we get a chance, you might want to ask questions about that later, but looking it up on their website might also be interesting. The immunogenicity sub-study specifically was intended to look carefully at the immune response to COVID vaccines in long-term care residents. As Dr. Evans has already pointed out to you, initial phase 3 trials cannot include subpopulations, and beyond immunocompromised people, the population that is least likely to respond well to vaccines and be protected are frail elderly residents of long-term care. So in the same way that we prioritize vaccines for them, it was critically important that we prioritize our understanding of how they respond to vaccines and how well they will be protected. So this sub-study is about looking at the antibody response in residents over time now to assess the third and further booster doses. And as Dr. Bowdish has already pointed out, to continue to look at breakthrough infections and to use these data to support our understanding of correlates of protection moving forward. Next slide. So this is our sampling time point for residents and staff. 200 long-term care residents were first sampled immediately before their first dose of vaccine. And you can see across the top that they are sampled more often in this study than the staff. And that's because we have a reasonably good idea in younger, healthier adults what immune responses look like, but we really didn't know what it was going to look like in long-term care residents. So for instance, you can see we put a 4-month post-dose 2 time point in because we wanted to detect early if we thought that waning immunity was going to be a significant problem. For the long-term care staff, we were not able to start quite early enough to capture everybody before their first dose, but you'll notice that we're also collecting saliva samples for long-term care staff, and that is to enable Dr. Gorman's lab at the University of Toronto to look specifically for antibody responses in the upper respiratory tract, which might actually turn out to be more important than systemic responses and antibodies in blood in terms of protecting people from maybe any infection, but potentially more minor infections. Next slide, please. So here's our data in the standard ELISA assays looking for antibody against the spike protein and a receptor binding domain, a piece of the spike protein that is responsible for binding to cells. And the first thing you can see is that Dr. Bowdish has pointed out, long-term care residents are different than immunocompromised people. The major problem here is not that they don't respond to 2 doses of vaccine. And in fact, we saw that outbreaks in long-term care facilities stopped almost immediately once we got 2 doses of vaccine into the residents of long-term care. The problem in residents of long-term care is more that their antibody levels wane much more quickly than antibody levels in younger and healthier people. And you can see on the bottom of the slide on the left that that's particularly true with the receptor binding domain, which may be a more important antibody in terms of protection. So that looking at this blue dot, you can see median convalescent levels by 6 months post their second dose of vaccine. There are a substantial number of residents who no longer have detectable antibody titers to spike or RBD. Now, we don't know that they're not protected, and we are keenly waiting for Dr. Bowdish and other people's cell-mediated immunity studies to help us with understanding what cell-mediated immunity does and what antibody does. But it certainly raised the issue that people here might not be well protected. Next slide. You can also see when you look at this that there are a variety of different factors beyond immunocompromise, which you could actually strikingly see even in our long-term care residents as a reason for non-response to vaccine. But there are a list of other things that are important. So starting at the top, as Dr. Bowdish has pointed out, you get higher levels of antibodies with Moderna vaccine as opposed to Pfizer vaccine. You get significantly higher levels of antibody in younger, healthier adults than in the frail elderly residents. The vaccines are made with the spike protein from the original, now called the ancestral strain of COVID, and you get better antibodies to those strains than you do to the current Delta variant. You get a significant decline over time. And the sum total of that, what that means is that when you compare a staff member who got Moderna vaccine and you're measuring antibodies against the ancestral strain 2 weeks post-dose, and you compare them to a resident who got Pfizer vaccine and you're measuring antibodies at Delta at 6 months post-dose, there's a 480-fold difference in the amount of antibody you can measure. And you can see from this that we still have a lot of analysis and a long way to go to tease out understanding those differences and what those differences might mean to infection and reinfection. Next slide. So we are just in the process of looking at post-dose 3 results in residents, and we hope in the next couple of weeks to get those numbers to decision makers. That is important because, of course, if people get a really good response to the 3rd dose of vaccine, that may help with us deciding if and when we're going to vaccinate older adults who live in the community. We also want to know, of course, about reactogenicity and adverse events associated with those vaccine programs, because adverse events to 3rd dose vaccines are important. And now, as we started the 3rd dose in residents and we're thinking about 3rd dose in other adults, there's a rethink about what time points we're collecting. What we're really interested in over time is looking at the people who get breakthrough infections and understanding how the immune response to vaccines correlates with breakthrough infections. Next slide. And finally, I just want to point out that there, as with all of these studies, there are a very large number of people who are part of these studies, and that the Immunogenicity Sub-Study is a small piece of the overall wellness hub study in long-term care COVID. And finally, next slide. Just to thank our funders and partners, and particularly to call out Dr. John Kim and Dr. Heidi Wood's group at the National Microbiology Lab, who have been very kindly supplying print assays, neutralization assays for our resident studies. Thanks very much.
Thanks, Alison, for sharing your work with us today, including looking at the factors that affect neutralizing antibodies. Our next presenter is Dr. Daniel Alcadzi. Daniel is a project manager and postdoctoral fellow at the Breer Research Institute. Daniel will be presenting about the Breer C19 immunity study. Dr. Alcadzi, the floor is yours.
Thank you, Nathan, and thank you for the CITF for giving us the opportunity to present some of our preliminary work today in the hopes that our work ultimately has a positive effect on the LTC sector. Our multi-province project is mainly focusing on understanding the underlying effect of COVID-19 on LTC residents, caregivers, and staff across 3 provinces, Ontario, British Columbia, and Quebec. So the main objective of our study are to understand the level and duration of vaccine-mediated protection in LTC residents, caregivers, and workers recruited from LTC homes in Ontario and British Columbia, and LTC workers recruited in Quebec. And secondly, we also want to investigate any factors that may be related to any observed diminished immune response or antibody response in vulnerable LTC residents. In regards to our preliminary data we're presenting today, we are showing results for 397 residents, 100 caregivers, and 920 staff recruited across 17 LTC homes in Ontario. Next slide, please. So firstly, we wanted to look at the overall antibody response in our 3 cohorts, the LTC residents being our study group, and LTC workers and caregivers are control groups. When it comes to overall antibody response, we're mainly focusing on the IgG antibody levels against the receptor binding domain, or RBD, on the left side, and the IgG levels against the spike protein on the right side. And this format will be consistent across the presentation. When looking at our fully vaccinated participants, we see a significantly lower levels of antibodies in our LTC residents compared to LTC workers and caregivers. Next slide, please. So moving forward, we wanted to focus specifically on fully vaccinated LTC residents to be able to understand what factors may be related to that diminished overall antibody response we are seeing. And here we are focused on fully vaccinated residents who have received the same vaccine, whether it's Pfizer or Comirnaty or Moderna, or it's called Spikevax for both dose 1 and dose 2. And what we see is that we have a strong antibody response after second dose that is more common with Moderna versus Pfizer. So if you look on the left side, we have a trend upwards of higher antibody levels for RBD. With Moderna, however, it's still statistically non-significant. And on the right side, we have statistically higher levels of antibodies, IgG, I guess the spike protein, with Moderna compared to Pfizer. More importantly, what we're not showing here is that regardless of what vaccine type they have received, what we're seeing is that these levels of antibodies are waning in fully vaccinated residents starting at 4 months post second dose. And obviously, this is a still ongoing analysis. Next slide, please. So moving forward, we wanted to stratify residents by age to try to understand whether age had any effect on that sort of diminished immune response. So when we looked at fully vaccinated residents ranging in age between 65 and 79 versus residents that were 80 years of age and above, we see that there's a weaker antibody response in older residents. On the left side, we see that there's significantly lower levels of IgG RBD in the residents that are 80 and above. Similarly, for IgG spike, we see also a diminished response in the residents that are older. What we are doing right now in ongoing analysis is to try to see other co-founder effects that may be interacting with age, just as the number of comorbidities that we are able to capture, as well as the type of comorbidities that may be interacting with age to overall affect the antibody response and the immune response in older vulnerable LTC residents. Next slide, please. So with that said, I'd like to first thank Dr. Amy Xu and Dr. Marc-Andre Langlois, who I'm presenting on their behalf, the co-investigators on the Briere C19 immunity study, as well as the entire team behind and our collaborators behind the C19 immunity study across the 3 provinces. The LTC sector, of course, and all our residents, caregivers, and staff that we have recruited. And lastly, the LTC homes recruiting our study and the on-site facilitators that we have developed a very close relationship with. Thank you.
Thank you, Daniel, for discussing the antibody responses that you and your team at Briere found across the long-term care homes in Ontario. Our next speaker is Michelle Canac-Marquis, a project manager at Uncover at the Research Institute of the McGill University Health Center. She'll be presenting on behalf of principal investigators Dr. Donald Vinn, Dr. Jean-Philippe Goin, and Dr. Diana Cruz Santiago on their study. Michelle, the mic is yours.
Thank you so much. I'm delighted to be presenting the Uncover project on behalf of our principal investigators. The Uncover study is our goal is to understand the COVID-19 vaccination elderly residents in Montreal, Canada, and Montreal, Quebec. And it's a joint and ongoing collaboration between the Research Institute of the McGill University Health Center, le Centre Intégré Universitaire de Soins de Santé et Services Sociaux, Centre Sud de l'île de Montréal, and the Centre de Recherche de l'Institut Universitaire de Gériatrie de Montréal. Next slide, please. To examine the evolution of the immune response to the vaccine in our elderly residents, we collected blood samples at the following time points. Keep in mind that in Quebec, we implemented a first dose priority system, meaning that the delay between the first and the second dose was 16 weeks compared to the recommended 3 to 4 week delay as recommended by Pfizer and Moderna respectively. So we collected samples before their first dose, and then 4 weeks, 8 weeks, and 16 weeks after that first dose, as well as 4 weeks after their second dose. And again, sample collection is ongoing. Next slide, please. The results I'm presenting today consists of 185 elderly residents. Their median age was 83 years old. 70% were female. The majority were self-identified as white. Almost all had at least one coexisting condition, and about half had previously diagnosed SARS-CoV-2 infection. Next slide, please. So looking at the graph on the right, we concluded that the 16-week delay between the first and second dose is likely the upper limit of the dosing interval. This is especially true in the frail elderly who were not previously infected based on the waning antibody levels that we see in the red trend line. Next slide, please. Next, we observe the difference in the antibody response among the different vaccine mixing strategies. This is a particularly unique feature of our study, given that 45% of our participants had Moderna as a first dose and Pfizer as a second dose. 35% had Moderna, and 20% had Pfizer and Pfizer. So our data shows that there was a difference in the kinetics of the antibody response at 16 weeks between Moderna and Pfizer at first dose. We conclude that this mix and match strategy achieves a comparable antibody response at 4 weeks post second dose. Using the same graph, I want to highlight, in addition to what has been presented from past panelists, that regardless of infection of SARS-CoV-2 infection status, the antibody response decreases significantly faster for elderly residents that received Pfizer as a first dose. Next slide, please. Using the same graph as the previous slide, we demonstrate for the first time of our knowledge the interchangeability of the mRNA vaccines in elderly residents at the second dose when looking at 1 month post second dose. And as mentioned earlier, sample collection is ongoing and we intend to continue examining this conclusion. Next slide, please. I want to end by thanking our dedicated team of researchers, study coordinators, research assistants, and as well and especially the dedicated healthcare staff, residents, and their caregivers who have continued to support us in this collaboration. Thank you.
Thank you, Michelle, for your work on this, especially looking at the interchangeability of the mRNA vaccine combinations. Our next speaker is Dr. Bonita Lee, an associate professor in the Department of Pediatrics at the University of Alberta. Bonita will be sharing her work on the study of the immune response and site-specific wastewater surveillance of SARS-CoV-2 in long-term care as early warning system. Welcome, Bonita.
Many thanks, Dr. Stahl. And first of all, I want to thank the organizer, CITF and CanCovid for this opportunity to present. Can I have the next slide, please? I first want to highlight that we actually have two components to the CITF funded study in Edmonton, Alberta. On the left side is the immunity study, and we have enrolled residents as well as staff from 13 long-term care facilities supported by 3 providers who graciously agreed to participate in the study. And for the participants who consented to the study, there will be not more than 4 times that they would have blood taken. And the intended time point of drawing blood from the staff or residents is pre-vaccine if possible. And if not, we intended to have blood draw at 3, 6, 12, and 18 months, looking at more long-term, antibody status. And there is one unique feature I want to highlight for our study, maybe not unique, but a feature that we, in order to minimize discomfort or stress, for the participant, if venous blood draw is not successful the first time, we would do a dry blood spot on a finger poke. And what we do is for participants that have a successful venous blood draw with an EDTA tube, we actually create dry blood spot from that tube, as well as processing the plasma for testing. And those dry blood spot and the plasma is tested on a bioplex assay, which is a quantitative immunoassay which provide us comparison between the dry blood spot and the plasma so that we can actually look at longitudinal result for staff and resident that have different blood sample collected over time. And also for the plasma sample, it gets tested with a neutralization antibody test, as well as different EIA assays so that we can look at correlation between different assays on neutralizing antibodies. And the second part of the study is on the right-hand side of the slide, is actually looking at the utility as well as cost benefit of using a site-specific wastewater-based surveillance for SARS-CoV virus RNA as an early warning system for identifying COVID cases in long-term care facility that hopefully can help public health do early outbreak investigation. Next slide, please. First of all, I want to do a introduction on the background of the demographic of our participant. And we can see we have almost like a 2-to-1 staff to resident ratio for the overall study. And the residents are definitely older with a median age of 86.2 compared to the 44.9, almost 45 for the staff. There is a higher female to male ratio among the staff compared to the residents. And for our study, actually, all of the residents has received Pfizer as the vaccine, and it's only 99% because there was one resident who were not vaccinated in our study. Compared to the staff, there is 1/3 of them actually have received Moderna and at the 2 dose. And again, the 1% show up is because there is one staff that got mixed vaccine with Pfizer as the first dose. Most of the residents got their vaccine within 21 days, very close, timing, but there is a more variability with the staff and also a longer time frame with the median being 38 days. And about a week before this presentation, about 85 of the residents have received the 3rd dose, and the resident that we have included in this study actually did get Pfizer at the 3rd dose. Next slide, please. Thank you. And with this slide, I want to focus on, it is actually focusing on the results of the neutralizing antibodies. So I want to do a shout out to Dr. Heidi Woods and Dr. Alicia Robinson at NML for helping us with doing this neutralization antibody test using an assay called plaque reduction neutralization test. And the other thing I really want to highlight is the table with the 3 months, 4 months, and 5 to 6 months is not longitudinal for an individual, but cross-sectional for staff and resident having blood collected at different time points. Because of ongoing outbreaks with the facility, sometimes with restriction of visitation, our intended 3 months collection get extended to 4 months and 5 months time. But the most important result I want to highlight, which has been, I think, demonstrated by some of my esteemed colleagues, is if you compare, people, staff and residents that have no known COVID infection before and after the vaccination, a much higher proportion of staff has neutralizing antibody compared to residents. And in the left-hand side of the table is a small number of staff and residents who had been infected with COVID prior to vaccination, that majority of them actually have neutralizing antibody for a long period of time. And we're going to investigate the 3 staff that didn't have it later on. Next slide, please. Going into the wastewater, testing, the graph is showing the orange represent, having a positive sample in the sewage, and you can see that detecting, virus in the sewage actually coincide with the blue background, which is the prevalence of COVID-19 in Alberta. And I think we all know we have a lot of COVID in Alberta. One thing I want to emphasize is with the sewage testing, it's easy to do. You can all imagine testing 1 sample of sewage, which represent all the residents, contributing to that sewage on that day, versus, doing hundreds of MP swab and processing them all for COVID testing. It is much easier to do the sewage. And the other thing that is important is we have demonstrated that with the sewage test, it is very sensitive. We can detect one asymptomatic person or symptomatic case in the resident in the facility. Next slide, please. In terms of the limitation, we are showing that, because with our study, we have resource to do twice a week testing. So without daily testing, sometimes we can miss a case because of the sampling schedule. And also residents who are using diaper, if their tissue or Kleenex is not being dumped in the toilet, we may miss them as well. We also sometimes have a positive test in the sewage, but we cannot identify the case at the site, maybe because it is someone who is not there every day, or someone who is asymptomatic and not being tested, or perhaps they had not consent to test it. And also we later on find out some manhole actually have one more facility, so it can make the outbreak investigation complex. Next slide, please. And last but not least, you can see we have really a big team. We have the wastewater management surveillance team and the immunity study team. And we cannot do it without all team members. Last but not least, I want to thank all the staff and residents, of the long-term care facility that we are doing the research with. That's all, and thank you.
Thank you, Bonita, for discussing the different components of your study and your preliminary results. Our next speaker is Dr. Mark Brockman, a professor with the Faculty of Health Sciences at Simon Fraser University and co-director of the Simon Fraser University Interdisciplinary Research Center for HIV. He will be presenting on the impact of older age on the immune response to COVID-19 mRNA vaccine study. Mark, over to you.
Okay, thank you, and thanks to the organizers for giving this chance to present some of our work today. Go to the next slide. So our study based in Vancouver is a little bit smaller than some of the other studies that you're hearing about today. The real goal of our project is to start to address some of the cellular immune responses to the vaccine. And so that work is ongoing, but our real goal there is to start to do more comparative analysis of the diversity of the B cell and T cell responses to the vaccine in younger people versus older people. So unfortunately, I don't have any data to present on that today, but I will provide an update on the serology responses that we've seen so far. So again, somewhat in contrast to some of the other studies that you've heard about today, our cohort is a bit smaller. We've enrolled 151 adults, 89 healthcare workers, staff of the residence facilities, 23 elderly residents, and 39 seniors from the community. The median age is shown here. Most of our participants have received the Pfizer vaccine or 2 doses of the Pfizer vaccine. And so we don't have the ability to really do comparative analysis between Moderna and Pfizer as some of the other groups have done. For the purpose of the time today, I'm just going to present our antibody response data that was measured 1 month after the second vaccine dose. That we have collected data following the first vaccine dose, 3 months following the second vaccine dose, and now we're beginning to do the analysis of samples collected following the third dose of vaccine. It's beginning to be delivered to our population. Again, just for the sake of time today, I'm combining the seniors from the community and the residents into one group for the statistical analysis. Next slide, please. So again, similar to some of the other studies that we've heard about today, so we've measured antibody response to the vaccine in a couple of different ways. What's shown here is binding antibodies against the spike receptor binding domain. So these IgG responses measured by using the mesoscale diagnostic system. Healthcare workers shown in the orange panel, the elderly adults, older adults shown in blue, and as a comparison, a group of individuals who had recovered from COVID-19 and also received the vaccination. So what we see in our cohort is that the long-term care residents and the seniors at 1 month following the second dose of vaccine display significantly lower binding antibody response, about 50% of the level of binding antibodies we see compared to healthcare workers and individuals who had recovered from infection and subsequently received the vaccine. Next slide. So we've also looked at the activity of the individuals, the immune activity against the virus using neutralization assays. I think similar to what was just presented from the group in Alberta. So we've been using a live virus neutralization assay. So this is the ability of plasma from these individuals to neutralize the kind of classic old Wuhan strain of virus in our level 3 laboratory. Again, similar to the binding antibody responses, we've seen that our older adults display about 1/4 the level of neutralizing activity compared to healthcare workers or individuals who had recovered from prior infection, received the vaccine. So again, this is getting into that red zone that I think we heard from Dr. Bowdish earlier on, that many of our older adults are kind of at that level of where we might anticipate they will not be displaying very good protective activity in their blood. And this is for us 1 month following the second vaccine dose. We continue to see decay in these responses, both binding activity as well as neutralizing activity over the first 3 or 4 months following the second dose. So again, I think our data is entirely consistent with the need for a third dose in particularly the older adult population. Okay, next slide. So again, we have relatively small numbers, but we have been able to do some multivariable analyses with our data, looking at the demographics of our cohort. We have a quite broad age range. Our youngest participant is 20 years old. Our oldest participant is 100. And so we have pretty good statistical power to look for other variables associated with the outcomes that we're detecting. We see significant associations between age and binding antibody activities, with about a 20% decline in binding antibody titer per 10 years of age, so increasing of age. We also see interesting associations between age, sex, as well as pre-existing chronic health conditions and the neutralizing activity that we're detecting in our population. So with every 10 years of older age, there's about a 15% reduction in neutralizing titer. We also see, interestingly, lower neutralizing activity among men compared to women in our cohort, and for each additional chronic health condition separate of age is also being associated with a lower neutralizing activity. Following the first dose of vaccine, we saw some impacts of chronic health conditions on binding antibody titers as well, but that is alleviated by the second dose of vaccine. So next slide. So I think this is just a summary of what I've already said, but really consistent with what everyone else has been seeing and reporting on today. Older adults in our population display significantly weaker immune responses, both binding antibodies and neutralizing activity following the second dose of vaccine, and certainly that diminishes over time after the second dose. And in our multivariable analysis, we've seen the age consistently shows up as being a significant driver of those lower responses. Okay, next slide. So I think just finishing up, I'll thank everyone on our study team who's been working on this project, including the groups that are interacting more specifically or more directly with the long-term care residences in the Vancouver area. Dr. Mark Romney is the clinical lead on our project. Sabrina Broom and I are involved in doing the laboratory-based analyses. So I thank everyone as part of the team. And next slide is also just to thank our funders, certainly from the CITF, but also funding from British Genome BC, CIHR, and Covarnet. So thank you.
Thank you, Mark, for highlighting your findings for us, including the virus neutralizing activity in older adults and the factors that you found associated with weaker vaccine immune responses. Our next speaker is Dr. Sharon Walmsley. She is an infectious diseases specialist at the University Health Network, director of the Immunodeficiency Clinic and research at Toronto General Hospital, senior clinician scientist at Toronto General Hospital Research Institute, and professor of medicine at the University of Toronto. She will be presenting on the STOP COVID study in Southern Ontario. Sharon, welcome.
Thanks very much, Nathan, and again for the opportunity to present today. Like some of the other speakers, many of us involved in HIV have shifted our work to COVID during the pandemic. Next slide, please. So STOP COVID is a different study than what you've heard so far on many fronts. So that is our acronym for the safety and efficacy of preventative COVID vaccines. And what we really embarked upon is evaluating the impact of these vaccines in community dwelling elderly, as opposed to the long-term care studies that you've heard so far. So our main research question was really, do older adults, and we were defining older adults as those over 70 years of age, Did they respond as well as younger individuals? And our younger cohort is, again, community dwelling individuals aged 30 to 50. And then our secondary questions are really to look at a number of other cofactors, including sex, comorbidity, vaccine brand, mixing and matching, and intervals on antibody peaks and duration. The other thing that I want to bring to your attention is that our study was completely digital, and this was a brand new way of doing research for us and for the UHN, and presented some challenges, but some real success in terms of our ability to engage the elderly community in research, and many people who've never participated in research ever before. And so this on the right-hand side is really our website, and this is how everybody got into our study tools and were able to participate. Next slide, please. So again, we were looking at older individuals, and again, I'll bring to your attention, our sample size is quite large compared to the studies that you've heard so far. And we were able to recruit 911 adults more than 70 years of age, and 377 adults between 30 and 50. And we accomplished this in 2 months, which was really quite unprecedented. And what the study participants did is, once they were identified, and how we identified them was through an email blast. So when people agreed to be contacted for research when they received their vaccine, we had a data sharing agreement with the Ministry of Health, and we were able to contact them with information about the study. We also use social media, and we use Zoomer magazine and their distribution list to get emails to tell people about our study. And once they went into the website, they then completed an electronic consent form. They did a baseline questionnaire about their health. And then within their portal, they would do a diary for the 7 days around each of their vaccine dose. And this was the way in which we were looking at safety. And then they were provided with a kit that they would collect their own dried blood spots, and again, on a schedule, and the plan is to collect them for over a year. And then they also get a feedback from the system every month to check in. How are you doing? Do you have any long-term problems from your vaccine? Have you developed COVID in the interval? And have you had any more doses? Next slide, please. So to demonstrate to you our characteristics, in the younger cohort, 3/4 were women, 60% were women in the older cohort. You can see that the vast majority, particularly in the older cohort, did identify themselves as Caucasian. And our younger cohort were really largely well, with very little underlying comorbidity. But you can see that our older population, a good half of them did have some degree of cardiovascular disease, which could involve hypertension or other cardiac abnormalities. 20% had had a diagnosis of cancer at some point in the past, and 14% did have diabetes. Again, you can see that there were some differences between the two age groups with respect to vaccine. That of the older population, about 2/3 got Pfizer for both doses, whereas for the younger group, about 47% got Pfizer for both. The younger cohort, about 20% got Moderna for both doses. And you can see that in both cohorts, there's about 15% that got mixed vaccines, which enabled us, again, to have some power to look at this vaccine mixing question. Next slide. So again, we use the laboratory of Anne-Claude Gingras, the same laboratory that Alison Mcgeer presented on. And we were looking at ELISA responses. We were looking at antibodies IgG to spike and to RBD, and they are presented as normalized ratios. And again, if I walk you through these graphs, they're very similar to the ones that Dr. Mcgeer have shown. The blue participants are older individuals. The pink are those between age 30 and 50. Now, our initial plan was to catch everybody before their first dose, but I think many of you are aware with the changing dates and times and moving of doses, we weren't able to capture many people before their first dose. So the vast majority of our participants we captured just prior to their second dose. And in these violin plots, every dot represents an individual, And the thicker the violin plot, that represents more individuals that have that particular value. The blue line represents the threshold of seroconversion in the lab. So if I walk you through the graph, and again, we do not have very many people before their first dose. So again, I caution you on the data that is presented, but you can see that 3 weeks after the first dose, if we take the younger cohort, the vast majority of them did have detectable antibody above threshold, whereas there was a much bigger splay of the antibody responses in the older cohort. If we then look just prior to the second dose, you can see now that of the younger individuals, the vast majority of them do have detectable antibody, but a good third of our cohort in the older age group did not have detectable antibody before the second dose to spike. However, you can see the enormous boost that people did get with the second dose, and you can see the levels going up dramatically in both the younger and the older individuals, well above threshold after the second dose. In terms of 12 weeks post-dose, we only have about a quarter of our cohort having been evaluated so far. And you can see that in the next set of graphs. So you can see that there's been a little bit of drop off in antibody levels at 12 weeks, but really not very much, and not very much difference between the age group. If we look at 2 weeks post second dose, there is a statistically significant difference with a better, higher antibody response in the younger than the older cohort, but we still have to do a multivariate analysis to see what factors are contributing to that. If we move to the next slide, this now is the RBD antibody responses as opposed to spike. And again, in our laboratory, most individuals get antibody to spike first, and then to RBD second. And I think you can see in this situation that clearly pre-second dose, a large percentage of people do not have antibody before their second dose. But again, we see this dramatic increase following the second dose. So this really reinforces the fact that that second dose is absolutely crucial in order to get significant antibody responses. Again, there is a statistically significant difference between our younger and older cohorts, but again, we have not yet completed the multivariate analysis to look at the factors contributing to that. If we look again at the 12 weeks, which is the last set of graphs on the right-hand side, again, we are seeing a little bit of drop off in antibody levels at 12 weeks post-second dose. Next slide, please. So again, getting back to the vaccine mixing. And what I'm looking at here is only reporting on the 2 weeks post second dose, looking at the antibody responses to spike and to RBD. So you can see that those individuals who got Pfizer for both doses had lower peak levels at 2 weeks than those who got Moderna for both doses. Whereas those who got the mixture look more like Moderna than they look like Pfizer. And then our last set of columns includes individuals that may have gotten AstraZeneca or other vaccines, and again, mixed vaccines. And again, their values are intermediate. So again, I think this data also reinforces that the mixing of vaccines was perfectly okay and that antibody levels were fine with the mixing of the doses. And again, like other groups have shown, that we tend to get higher antibody responses in those individuals who got Moderna for both of their doses. Next slide. We also wanted to address this whole issue of the gaps between the two doses. And when we started the study, it was recommended that people get their 2 doses on schedule, but almost as soon as we started, that gap did get extended and then it got shortened again. So we had a moving target. But what we attempted to do was to look again at the anti-RBD antibodies before the second dose, which is on the left-hand side. Again, the pink line is the younger individuals. The green line is the older individuals. And you can see the longer the time between your 2 vaccine dose, the lower the antibody level before that second vaccine. And that was particularly important for the older individuals. However, if we then looked at 2 weeks after the second dose, that difference all went away. and that the difference in time between vaccine doses of 1, 2, 3, or 4 months did not make any difference, and the peak levels of antibody were the same regardless of that time interval. So it became important before the first dose, but seemed to disappear after the second dose. Next slide, please. So again, just back one if we could, I would just again like to thank all of my study team, including our investigators, and particularly my research manager and project manager and statistical help that have really been instrumental in us getting this data to you in timely fashion. And clearly the digital team that allowed us to develop this electronic system, which enabled us to be able to recruit patients in such a fast period of time. And last slide, again, to our funders, the CITF, but also a grant from the UHN Foundation and the SPEC family. I thank you.
Thank you, Sharon, for you and your team's work on this important study and for sharing the results by vaccine type and the impact of dosing intervals on the antibody levels. I believe Dr. Tim Evans will now provide his conclusions based on the results we've seen today. Tim, welcome back.
Thank you very much, Nathan, and thanks to all the presenters who managed to take enormously great breadth of results and distill them down into 5-minute aliquots of really very interesting findings. So thanks very much. I'm just going to try and pull together some of the big picture things that I think emerged quite strongly from the presentations. Next slide, please. The first is, I think, that residents of long-term care are experiencing waning immunity much faster than younger, healthier adults. And that this is seen also in neutralizing antibody response compared to younger adults. The neutralizing antibody levels after 3 to 6 months post second dose are low. And there does seem to be a consistent finding that the Moderna vaccine seems to elicit a better immune response, at least by the figures that are being shown, compared to Pfizer in residents of long-term care. And perhaps beyond, as we just heard with Dr. Walmsley's study. The understanding of the immune protection, I think, was stated across the studies as being not simply looking at the individuals per se, but also the environments they live in. And that's particularly true in long-term care settings where you have very dynamic and complex interactions with staff and visitors. Next. So the limitations to the interpretation of results is that we haven't seen clinical correlates, and I think this is an important continued piece of data that we need to look at. And this is the recognition that although the antibody levels might wane, this does not necessarily mean one is vulnerable to disease. We heard about the need to look at cell-mediated immunity markers. That's underway. That might give us a better sense of protection, but also if we do observe clinical breakthrough, then that may also help us get more understanding of the significance of this antibody wane. However, I think given the pervasive findings that were found across all of our long-term care settings in terms of the wane, and in view of the history of this population being particularly at risk, I think the policy recommendation is sound in so far as recommending the third dose, particularly for residents of long-term care. So this is, I think, acting on the side of being vigilant with respect to safety rather than waiting too long and being sorry. So I think next slide. Back to you, Nathan.
Thanks so much, Tim, for covering these key findings with us. In the interest of time, I'm going to quickly touch upon the implications and long-term considerations before we open it up for questions. So we've seen from a number of our presenters that long-term care residents are a vulnerable population whose immune response to vaccination should continue to be monitored. We've seen that, third doses and the policy changes that have taken hold across our country may help to increase antibody levels, but some residents, as we've seen in other populations, may still not mount an adequate long-term antibody response, or they may experience faster waning from third doses itself. Next slide, please. We also know because of that, because they remain a vulnerable population and because they have less robust responses to vaccines compared to other populations, the necessity of vaccinating everyone around them, including staff members. So many individual institutions, some provinces like British Columbia, as an example, Nova Scotia is another, have done things, and Ontario as well recently in the long-term care setting to make mandatory COVID-19 vaccination, but there's still a lot of work to do in encouraging, supporting, and assisting as many individuals around these long-term care residents to get vaccinated, but especially the staff that do provide that direct and hands-on care. But overall, as we've seen in much of the other pandemic, or much of the rest of the pandemic, that what happens in the community in many ways will sometimes get into the long-term care homes. And so surrounding ourselves with as many vaccinated people, both within the homes, most importantly, but in the larger community outside of long-term care homes is extremely important. Next slide, please. So I also think, vaccination, as Dr. Bowdish said, was really miraculous, particularly during the third wave, end of the second wave, but into the third wave in terms of protecting these populations. But we've seen throughout the pandemic that what has been revealed here is that there are significant underlying factors that allowed COVID-19 to be so devastating in long-term care homes. And many of those factors were likely present beforehand for other transmissible infectious diseases like influenza. So, vaccination is a fantastic tool and a fantastic protection for these residents, but we also need to think about some of the other factors that have been identified as contributing to the high mortality and suffering we've seen inside long-term care homes and among long-term care residents and staff. So factors that have been identified are crowding within long-term care homes and multi-occupancy rooms, the older design standards. In Ontario, we have homes that meet or fall below, not homes, tens of thousands of homes that meet or fall below design standards that were established in the year 1972. And so these have poor ventilation. There are ongoing staffing issues, and there are issues with infection prevention and control. And so, fixing these structural factors will help long-term for COVID-19, but will help for these other conditions as well, and should be done even as we promote vaccination, as we give third doses to long-term care residents, as we try to maximize vaccination for COVID-19 among staff as well. Next slide, please. So one of the things that as we start to open the floor for questions, we just wanted to remind you here that the summary of this presentation and the availability of its contents will be available at the CITF website, COVID-19immunitytaskforce.ca. As we open the floor for questions now in the remaining 21 minutes that we have here together, I'd like to introduce Doctors Anne-Claude Gingras and Sharon Strauss, who will be joining us for the portion of today's event. Thank you both for being here with us. And now to the members of our audience, if you haven't already done so, please enter your questions into the Q&A section at the bottom of your screen. We will do our best to answer as many of them as possible in the remaining time. So let's start with the first question, which is for Dr. Mcgeer. Do we have an understanding of how effective memory B cells respond to production of antibodies against COVID-19 or SARS-CoV-2, more precisely in this age group? Is there a relationship between waning antibodies, as we are discussing now and in the news, and the memory B cell effectiveness?
So an excellent question. What's actually happened is we've kind of skipped over understanding memory B cells, which is really important to go back to, and gone directly from antibody levels to protection. So no, we don't understand the memory B cell response well, and we need to. But what we do know is that in temporal association with the decline in antibody levels, that there's also been a significant decline in vaccine efficacy. It's been seen in multiple jurisdictions, although I think the nicest work is Jeff Kwong and the Canadian Immunization Research Network study out of ICES. And what those studies demonstrate is not only declining immunity in long-term care residents, in terms of protection against infection, but also that difference between Moderna and Pfizer, where you can see that the protection against Moderna appears to be longer lasting in parallel with higher antibody levels. Whether that's really antibody levels or something about B cell immunity we don't understand yet, open question.
Thanks, Alison. This question is really open-ended to our panelists and speakers. You know, we've heard a lot about the interval between doses 1 and 2 for the more general population. Long-term care residents in Canada, not in every province, but in many provinces and territories, stuck to the tight interval, really to minimize that sort of, well, to be faithful to, at that time, some of the clinical trial protocol, but more so, I believe, to minimize that sort of valley of vulnerability between doses 1 and 2, because we were really having a huge amount of community transmission and outbreaks at the time. But for anyone who has been able to look at this within their actual immunity study results, how has the interval played out specifically among long-term care residents in terms of the effectiveness of the vaccine? I don't know if anyone has an answer to that.
I don't know if nobody else will dive in. I'll go out on this advantage. I think I don't know that we have good data from long-term care, although we did say from the Montreal group that you do see a decline between doses, and maybe the longer interval actually gets you as good a response to Pfizer as it does to Moderna. So to me, seeing these data from across the country in a whole lot of different circumstances really enhances the value of our detailed understanding of how people respond. But we do know from the general population, both from Jeff Kwong's data at ICES, Denise Skowronski, and the BC Center for Disease Control data, that you do get a benefit in protection from extending the interval out probably to 8 weeks. And honestly, as you pointed out, Nathan, we knew that to be true when we started, but we didn't ask vaccine companies to give us perfect protection. We asked vaccine companies to give us protection fast. And so the trials were done with shorter than usual intervals, ones that we knew might have less response, because we wanted to ensure the protection for the most people in the fastest positive way. But we're definitely learning now that longer intervals, probably 8 weeks is probably the interval that gives you the best, at least antibody response. We can talk later about whether it gives you the best cell-mediated response or not.
Thanks, Alison. Sorry, go ahead, Bonita.
Sorry, Nathan, I just want to mention one thing. For myself, I'm definitely still learning what does all these antibodies test results mean. So very lucky to have, a functional neutralization antibody test with a in vitro system, with Dr. Heidi Woods and Dr. Alison Robertson, but definitely working with, Dr. John Kim's lab and Dr. Anne Clo's lab as well, to look at when we have a machine telling us, the level of antibody, how does it correlate with functional antibodies? And I know also in the future, I'm hoping to be able to share with you guys as we learn like neutralization antibodies expressed in international units, so that it's all more comparable as well. So we just want to say that. Thank you.
Thank you. I think I suspect we may not answer this, but can we conclude that breakthrough infections in the elderly were lower in the cohort who received a first dose Pfizer and a second dose Pfizer vaccine, as opposed to those who received presumably Moderna and then Moderna? Or I don't know if we have the data, but those who received Pfizer and then a Moderna vaccine?
I think the answer is we don't know yet. Those data will be coming. It's a relatively complicated question because it's not just about the breakthrough infections, but how the breakthrough infections happen. So if you have a big outbreak, is that because you had difficulty controlling transmission or because residents got Pfizer? And that's a question we can probably get closer to answering with some time and effort, but it's not as easy a question to answer as it sounds.
Can I just comment a little bit that while we don't know that, as far as I know in our cohorts, luckily because we don't have that many, breakthrough infection, that many outbreaks, that results that are coming from different places in the world, particularly a study that has been done recently by the Mayo Clinic in the US, shows actually the opposite, that there are less breakthrough in people that were double vaccinated by Moderna than double vaccinated by Pfizer. And this is an agreement, in fact, with what has been found in studies in different settings, including in Qatar. So I think, while this is true that we don't know that in the context of the Canadian population, and especially the LTC Canadian population, that the evidence of real world evidence of vaccine efficacy is that Moderna gives you actually not only a stronger protection, but also protection at long term. And this might be associated with the data that many groups have showed today, that a double dose of Moderna actually induces higher immune response. Also has higher side effects, by the way, right?
Let me ask an off-script provocative follow-up to that, which is if someone received Pfizer and Pfizer, is there any merit in boosting their third dose with a Moderna vaccine? Because I've been asked this many times personally, and I know there's not data to support this directly, but I was curious for your expert opinion on that. Dawn.
We discussed this with some of our partner homes because our study, we had 23 different homes, and some of them had Pfizer, some of them had Moderna, and some of them were asking what for their third shot. Some decided they wanted to stick with what they'd already had. Some decided they wanted to switch. And so primarily based on some of the data we've seen. So although we don't have the answers yet, there have been a couple other studies in transplant patients or people who are immunosuppressed. And to be honest, I think some of the data we've even seen today is very suggestive that Moderna might be the right choice for that boost. And I think this is really hopeful for us because now we can start thinking about how to use vaccines smarter. We can, these are precious resources. We need to use them as soon as they're needed, but not sooner, so that the rest of the world can be vaccinated. And by making good choices about which one we use, we may ultimately reduce the total amount of vaccines required, or at least delay them and give the rest of the world time to catch up. So there are data in transplant patients and immunosuppressed that suggests that Moderna may help restore some of that. And I hope that in the next few weeks, we'll start getting the results from our first antibodies from people who, the homes that chose to mix and match.
And Claude?
Just to add, I fully agree with Dan, of course, but just to add to that, so there is a distinction between what in the US is considered a booster dose of Moderna, which is actually a half dose, and what is considered a third dose of Moderna, which would be the initial 100 microgram dose. And I think it's important to realize that Moderna is not Moderna, right? It's dose dependent. And so if you have a population that is like the LTCH population that is having issue building a strong immune response to the Pfizer, which is actually low dose, maybe using a full dose, third dose of Moderna rather than the booster dose that's currently being used in the US would be important. So again, like this is something to keep an eye on, that there is a brand of the vaccine and then the amount that's actually in the tube. And that's going to be the same for the pediatric cases, right? So the vaccine for kids are the same brand and the same formulation, but different amount.
Thanks very much. Relatedly, we have a question whether we can speculate on whether a fourth dose will be needed in another 6 months' time. Presumably that might relate to the last question in terms of the selection of the booster vaccine and the dose, but I will throw that out to this group of experts as well.
Yes, Bonita, I definitely don't have the answer to this question, but I think besides looking at, the immune or antibody response, as we learn, is how is the virus is going to behave. I sometimes call, viruses are not very bright because they make mistakes as they replicate, but then as they come up with new mutants, we might have to respond differently as well with changes in vaccine.
And does anyone else want to stick their neck out on fourth dosing?
I don't think so. Well, one of the interesting things about watching this is that if you do vaccines for a living, you're always in the circumstance where you don't know if another dose is going to be needed. And we have routinely, we've added doses to measles, we've added doses to pertussis vaccines, right? We go out with what we think is reasonable for protection in the short term, and then we watch for longer term protection. And so I think we've all given up asking the question. You just can't tell. But if you're new to the world of vaccines, it's just really frustrating for people to look at you and say, I have no idea what we're going to need in 6 months. And so, I'm kind of hoping that when we get to the end of this, that we'll all have had a lesson in vaccines, and that will be one of them, that we understand that when we introduce a new vaccine, we know some things we know in the short term about how we're going to use it, but there's an ongoing learning process about how we best use it in the longer term.
Thank you. Karen Palmer asks, how many days, hours after the third dose do we begin to see improved immunity in older adults? She asked this because the province has apparently classified or prioritized boosting based on a shortened interval. So caregivers, including those providing care to older adults living in the community, and third doses to all those community dwelling older adults who are 70 plus. I wonder, so I guess the first question is, how long does it take to elicit an adequate immune response after the third dose? And secondly, how should the interval play into how we prioritize boosting community dwelling older adults and caregivers?
So I don't know the answer to the first question, but I can tell you that both in our study in a long-term care outbreak whose first dose vaccine started at the time, exactly the same time as their outbreak started, and in a study that just came out today in Lancet Infectious Diseases in the UK, that you actually see a reduction in the severity of infection within days of the first dose of a vaccine. So I would expect that you would see that same benefit with third dose vaccines, maybe even a little faster, because you'd expect an anamnestic sort of reminder response after third doses. Certainly a week or 10 days post third dose, you would expect that to kick in. And I think the choice of the reason I think that British Columbia is recommending that people who got early short interval doses are prioritized for the first dose is a combination of things. The first thing is that those people will have had a somewhat lesser immune response because they had a short interval, and they are also by definition longer after their second dose. So if you're going to take a group of people who are most likely to be at some risk of waning immunity, those are the people who are highest risk and might benefit the most. We might also want to prioritize caregivers in long-term care, because it's likely that the third dose will also reduce the risk of mild infections, and that in turn will reduce introductions into long-term care homes and result maybe in fewer outbreaks in long-term care.
Thank you. We have a very macro question, which is, how will we move from an epidemic to endemic with vaccinations going forward?
I'll take a stab at that, but my colleagues will jump in because I think we've all got strong opinions. When I first saw the clinical trials for our mRNA vaccines, I thought, great, we're really going to be able to sort this out, right? Because the original strain of the virus to which we're all vaccinated against, the vaccines were so incredibly efficacious. And, you know, if there was any carriage or transfer in vaccinated people, it seemed to be really, really minor. And so I thought, wow, we're really going to be able to get back to our old lives. And then what I wasn't expecting was the political or the human aspect of allowing billions and billions and billions of these viruses to replicate throughout the world in various parts of the world and generate these variants of concern. And so now we're living in a situation where our vaccines are wonderful, but slightly imperfect. And so there will be no herd immunity, no matter what we do. We will always be in this situation where our most vulnerable, today we all have a vested interest in long-term care residents and older adults, but think also cancer patients, transplant patients, the very, very young before they're vaccinated will always be at risk of becoming infected with those of us who are vaccinated. And so I can't predict the political aspect. I don't know which variants will be allowed to emerge. I don't know which countries will become the generators of these next variants. But I think in order to make that transition as seamless as possible, I think we all have to advocate for our policymakers and the people who can make these decisions to commit to vaccine equity. To protect the vulnerable people here at home, we need the rest of the world to be vaccinated as well. And honestly, I think the political angle will have more effects at minimizing this for us at home and Canadians and for our vulnerable populations than almost anything else. So that's my 2 cents.
Anyone else have strong thoughts on that?
Actually, I really want to thank Dawn for mentioning about the vulnerable population. And I think besides those who are medical vulnerable, there are a lot of vulnerable due to social, other situation that also, need to be vaccinated. There are patients who, besides like the immunocompromised, like pregnant women who can get more severe disease and they also need to be protected. But I know today we're focusing on long-term care facility. And I'm just thinking that the virus is going to stay. We will never have zero virus. But overall, I think one of my public health colleagues, Dr. Dina Hinshaw said it well, is somehow it will be different for each, I think, community and population, that the balance need to be achieved either with vaccination or some restrictions measures so that the healthcare system doesn't get overwhelmed with too many people with severe illness and surgery being canceled and people are not getting looked after. I don't think there would be one answer for everyone. It would be all different, but I totally agree with Dawn. We all hopefully strive to work with our policymakers to try to keep everyone as safe as we can.
Thanks, and I think that underscores the importance of working on the structural factors as well. And just to highlight that, the structural factors being staffing and buildings and the other infection prevention and control within homes, because there will be vulnerability that remains. And as a sort of segue, CanCOVID's about to release a report on the underlying structural factors in the Netherlands and Denmark that were felt to be important during the COVID-19 pandemic. I guess another sort of an interesting question here, which is that many of our long-term care policies, whether it's visitor policies, testing policies, and frankly, vaccine certificates for the broader population, are differentiating between those who are fully vaccinated and partially vaccinated, and of course not vaccinated at all. How will our definition of fully vaccinated evolve as we roll out booster doses? And how should policies take that into consideration? I feel bad picking on somebody, but then Alison ultimately ends up answering.
I said grin on Anne-Claude, but I'm waiting for Anne-Claude.
Yeah.
I think so. I think the first thing is that what I'm really hoping for, okay, is that third doses for long-term care residents lock in antibody response that is protective in the long term. Okay, I'm not holding my breath. It's probably not the most likely outcome, but if that's true, then vaccine mandates become irrelevant very quickly, and we can just walk away from them, and that will be lovely. Okay, we won't have to worry about healthcare workers protecting the people they care for, because we'll be able to protect our most vulnerable people. We may still have to worry about immunocompromised folk in the population. Okay, this is a different question and a different response. So I think what that tells you is that it's another one of those questions that we can't have an answer to until we know how people respond to third doses and what happens, because we could end up in an ongoing situation that is similar to the situation we have now, where there is undeniably a risk of introduction into long-term care, no matter how careful you are, and that needs the layered approach and a lot of work on trying to fix the structural factors in long-term care. And the alternative is that third dose will fix everything, and which is not that we shouldn't work on structural factors in long-term care, but that they'll become much less important for COVID. Ask me in a year.
Okay, thanks very much. Unfortunately, we're out of time. So just a couple of very brief announcements. On behalf of CITF and CAN-COVID, I'd like to thank today's speakers and attendees for sharing your time with us and contributing to this important discussion. We know how busy you all are, so we appreciate you taking time out of your day to join us. Secondly, this event will resume in December, where the featured topic will be COVID vaccination and infection in pregnant people and the health of newborns. Until then, you can catch CAN-COVID's other events by visiting our website. Finally, if you're interested in seeing any of today's publications referenced in today's event, you'll find them listed on CITF's website and at the end of this event's recording. And I know we didn't get to all the questions. I know we've captured those, and we will try and get responses to the 3 outstanding questions we did not have time for. So this concludes today's event. Thanks again for joining us, and stay safe, everyone.
We would like to thank today's speakers and attendees for their time, as well as the members of our networks for their continued support and participation in Canada's pandemic response. If you are interested in attending our monthly research results and implications events, please visit either website for more information.